today I'm going to give a bit of an overview of my PhD work and some of the projects that we've done surrounding using 3D ultrasound for gynecologic brachytherapy procedures. And so gynecologic cancers are among the most prevalent cancers in women worldwide, and we see the number of malignancies increasing. And yet, despite this, discussion of these types of cancers is often still stigmatized, and they're often overlooked as an area of research, which is why I was really excited to see today that both of our talks are in the area of gynecologic cancers. This class of cancers typically includes 5 different types, so that's cervical, endometrial or uterine cancer, vaginal, vulvar, and ovarian disease. The procedure I'm going to discuss today mainly pertains to cervical cancer, as well as some cases of endometrial and vaginal cancers. And even within these 3 types, there tends to be very diverse presentations in challenging anatomical locations, and they tend to be associated with highly variable disease geometries. And so there often isn't a one-size-fits-all solution to the problems facing the treatment of these cancers. One treatment option is known as high-dose rate interstitial brachytherapy. And so in this procedure, the needles are temporarily inserted into the tumor itself and the surrounding area through a template on the patient perineum. So you can see the template at the bottom here, which includes a grid of holes for the needles to be inserted through, as well as a cylinder that's placed into the vagina for stability during the procedure. So once all the needles have been placed, typically about 15 or so at our institution, a high activity radioactive source can then be brought to planned positions within those needles in order to irradiate the tumor from the inside out and preserve as much surrounding healthy tissue as possible. Ideally, in order to do this, the implant has parallel needles with about 10 millimeter spacing. However, typically an acceptable implant may be achieved with about plus or minus 5 millimeter spacing. So currently, patients typically receive a preoperative MRI in order to provide information about the tumor itself. They then have the procedure to place all of the needles, following which they receive a post-insertion CT scan or MRI at some institutions in order to verify where those needles went. But really where the question lies is in what can we do intraoperatively to visualize those needles as they're actually being placed. And this leads to an important clinical need because precise placement of these needles is necessary to avoid overexposing nearby organs at risk, like the bladder and the rectum, and also to deliver optimal treatment. And yet, despite this, there's currently no standard method to assess those needle positions intraoperatively. Currently, the needles are typically placed based off of preoperative images, like the MRI you see on the right. Occasionally, 2D ultrasound may be used. However, it's not standard, and it's often difficult to localize the needles on those 2D views. Some institutions have proposed imaging techniques using CT or MR guidance. However, in order to do this intraoperatively, this requires very specialized procedure suites and equipment, which limits access to only a few institutions worldwide. Additionally, these approaches tend to be associated with very long treatment times under general anesthetic. And therefore, the objective of our work was to develop a versatile 3D ultrasound needle guidance system for use during high-dose rate interstitial brachytherapy of gynecologic cancers. And so we hypothesized that this would allow us to visualize our needles approaching our organs at risk. And so this provides the potential for accurate intraoperative assessment of the interstitial implant, which would allow those needle positions to be immediately refined. As well, it has the potential for improved implant quality, which would facilitate optimal dose distributions with potentially fewer needles placed as well, and the potential for reduced risk to those nearby organs, which would limit overexposure and complications. And so here you can see a prototype of our 3D ultrasound imaging device. So it makes use of a conventional 2D ultrasound probe that's already available in the operating room. And that probe's placed into a probe cradle and rotated through a range of motion using a stepper motor in order to generate the image. This large silver piece that you see surrounding it is just a stabilizing system which connects to the patient's bed and supports the system and prevents any motion during image acquisition. So as I mentioned, there often isn't a one-size-fits-all solution to the problems facing these cancers. And so we decided to include 3 different imaging modes in our system in order to account for that variability in patient geometry and anatomy. And so the first mode is a 170-degree Sidefire transrectal ultrasound, which generates sort of a fan-shaped image. The second is a 360-degree Sidefire transvaginal ultrasound, which generates a ring-shaped image. And the last is a 3D Endfire transvaginal ultrasound, which generates sort of a dome-shaped image. And so here you can see the device during operation as one of those 360-degree scans are performed. So on the top frame, you can see the probe rotating through that range of motion. In the bottom right, you can see the live view from the 2D ultrasound machine. And in the bottom left, you can see those 2D frames being placed into the 3D volume as they are required, with a full scan taking about 20 seconds or less, depending on the mode that's selected. And so the first mode I wanted to talk about was our 3D Sidefire transrectal ultrasound approach. And so here you can see an example of a patient image taken with the 3D transrectal ultrasound, which has been aligned to the clinical CT. And so you see those blending in and out together. And so if we then look at those side by side, in both we can clearly see the bottom edge of the vaginal cylinder. As well, we can see the Foley catheter in the patient's bladder. And there's 2 needle tips that are visible in this image field of view. And so for this study, we included 5 patients as a proof of concept, and they had a variety of characteristics, but all had vaginal disease sites. And so across those 5 patients, there was a total of 73 needles placed, of which we were able to visualize 64 and identify the tips of 58. And so for those 58, we had a mean tip difference of about 3.8 millimeters when comparing the ultrasound to the clinical CT. And we had a mean angular difference of about 3 degrees. And so we found what the advantages of this approach was that they required minimal modification to the current workflow in the operating room. And it also provided really clear visualization of posterior needles and any needles that were inserted deeply. However, the main limitation of this approach was that the vaginal cylinder created a large shadowing artifact on the anterior side, which really obscured any needles placed in this anterior area. However, this can be mitigated by using a Sidefire transvaginal approach in cases with more anterior needles. And so in order to do this, we took the solid clinical vaginal cylinder and we replaced it with a hollow cylinder made out of a sonalucent plastic, meaning that we can take an ultrasound image through the plastic. And so this cylinder has the same outer dimensions as the clinical one, but has a hollow core to accommodate the ultrasound probe. And so this is an example of a patient image from that study, where in this sagittal view, the needles appear as these linear structures. And in these images, the ultrasound probe is in the center, surrounded by that cylinder. And we were really excited about these images because not only were we able to really clearly visualize our needles, we were also able to see a lot of other key features. So in particular, we could identify our organs at risk, such as the patient's rectum, as well as the patient's bladder with the Foley catheter in place. As well, in this reconstructive view, we're able to see these bright spots, which are the needle cross sections surrounding that cylinder. And so again, we took our 3D ultrasound image and we aligned it to the current clinical CT image. And so here you see those blending in and out together. And in the center, you see the vaginal cylinder with 1 needle visible in this image. And so for each needle, we selected the first and last point along the needle path that was visible within the image. And we called these our entrance and exit points. And so for this study, we included 6 patients, again, with a variety of characteristics, but all having vaginal disease sites. And we imaged 8 to 10 needles per patient for a total of 54 needles included in this study. And so for each needle, we took the maximum of either the entrance or the exit point difference. And so doing that for each needle, we had a mean maximum point difference of about 2.4 millimeters. We also looked at the angular differences again. And so here in yellow, you can see the manually segmented needle model from ultrasound. And in blue, you can see the model based on the CT image. And so we found a mean angular difference for our 54 needles of just under 2 degrees. And I did want to point out one interesting case Here we had a patient that had more laterally placed needles on the edges, and we found that these needles had very large angular differences, and they tended to be more parallel to the rest of the needles at the time of ultrasound imaging and more angular at the time of CT. And so we think that this is most likely due to the shift in the patient posture between the acquisition of the ultrasound and the CT, which is about 2 hours later, and also could be a byproduct of some swelling and edema. And so we found the advantages of this 360-degree approach to be that our needles and anatomical features were very clearly visible. In particular, we were able to see the bladder, rectum, and Foley catheter, as well as the urethra, pubis, pubic symphysis, and the vaginal wall itself. And so we found the main drawback with this approach was that if needles were inserted deeply, the tips weren't visible within the field of view of the ultrasound image. And so we're hoping to mitigate that by incorporating the 3D Endfire transvaginal ultrasound as well, which to date has been tested in a pelvic phantom study. And so this phantom includes a template that mimics the clinical procedure, and we inserted 6 needles as a proof of concept. And so here you can see overlaid on the CT of the phantom box, both a 3D Endfire and Sidefire transvaginal ultrasound image. And if we blend in between those modalities, we see that we get different information from each approach. In particular, we get really clear needle trajectories from our Sidefire image and needle tips from the Endfire. And so in our phantom study, we had a mean needle tip difference of about 1.9 millimeters and a mean angular difference of about 1.5 degrees, which we think is adequate to continue investigating this in a future patient study. However, one challenge that we had with all of our imaging modes was the ability to quickly localize our needles, which would be really important to translate this system clinically into the intraoperative environment. And so looking at our 360-degree transvaginal ultrasound images, since we had really clear views of our needles in this method, we looked at both our 3D images as well as the 2D ultrasound images, which we actually provide to our clinicians with an indicator of their position within the context of the 3D ultrasound image for a better idea of where those needles are relative to different key features like our organs at risk. And so using our 2D ultrasound frames to mimic sort of a live clinical scenario, we implemented a 2D automatic segmentation method leveraging a deep learning technique. And we also performed a 3D automatic segmentation on the 3D images using a randomized half transform to simultaneously segment multiple needles for a sort of bigger picture view in the broader context of the implant. And so in order to do our 2D automatic needle segmentation, we used a convolutional neural network with a modified unit architecture. And we used 262 images from a variety of interventional applications in order to get a large enough data set to perform both training and testing. So our data set included images from prostate brachytherapy, liver ablation, as well as phantom procedures, kidney biopsy and ablation procedures, and some gynecologic brachytherapy images. And we split this data set into 71% for training and 29% as an unseen test set. And so this meant that we had 34 gynecologic brachytherapy images included in our training set, and we reserved 18 as unseen images to test on. And so here you can see an example of a segmentation from that. And so in this 2D frame, you can see a needle which passes through an air artifact. And so in yellow is the ground truth segmentation of where the needle is. And now overlaid in blue, you can see the algorithmic segmentation of the needle. And so you can see that it's slightly perturbed by the air artifact, but in general aligns quite well with the true needle trajectory. And so for our 18 needles included, we had a mean point difference of about 1 millimeter with this method and a mean angular difference of about 0.7 degrees, which we think is promising to allow for intraoperative localization of our needles during this procedure. Right now, The algorithm takes about 50 milliseconds per needle, and we're hoping to speed that up a little bit more to allow for real-time live segmentation in video streams to allow our clinicians to monitor those needle positions as they're inserting them. However, we also wanted to be able to simultaneously segment multiple needles to allow for an overall assessment of the interstitial implant while our clinicians were still in the operating room and still had the ability to modify the needle positions. And so we implemented this using a 6-step method that was originally developed by Hrinovich et al. For prostate brachytherapy. And we modified this approach to account for the differences in the image geometry and the appearance of the needles and gynecologic brachytherapy images. And so briefly, this process uses a filtering step with a 3D convolution kernel to enhance any edges that are the same width as the expected needle. It then looks at the intensity peaks to generate potential feature points and identifies candidate trajectories using a randomized 3D Huff transform. We then refine those trajectories to include as many feature points as possible, and we label those candidate trajectories with their template positions. And then finally, we localize the endpoints of the needle within the image. And so we first tested this in a proof of concept patient image with 8 needles that you see here. And so again, here you can see the ultrasound model needle in yellow and the algorithmic needle shown in blue. And so we found there's quite good agreement between these, and you can see that as well in the oblique view. And so we went on to test this in 5 different patient images. And so there was a total of 50 needles included in this study, and we had a mean maximum point difference of about 1 millimeter and a mean angular difference of about 1.2 degrees. And so again, we felt that this was adequate to give an idea of the quality of the interstitial implant in the intraoperative environment, with the 3D approach taking about 30 seconds to give the output of needle localization. And so we felt that adding these tools would really improve the clinical translation of this system. And the other aspect that really helps with the clinical translation is the versatility of this approach. And so we're starting a new study now to look at intracavitary applicators. So instead of that interstitial template that I showed you at the beginning with the needles that are inserted through it, here we have a variety of applicators, including a ring and tandem, which goes into the vagina and the uterus, as well as a tandem and ovoids applicator, which is sometimes known as a Fletcher applicator. And there are also a variety of hybrid applicators which combine these intracavitary approaches with interstitial needles. And so currently, these applicators are typically evaluated and planned using MRI or CT. And so really our big question was, is there the potential to be able to plan with these applicators using a 3D transrectal ultrasound? And this is of particular interest because these are typically used for cervical cancers, which has a really high prevalence in developing countries, which tend to be lower resource centers. And so here's an example of an image from our preliminary patient in this study. So as a reminder, the tandem and ovoids applicator, which was used for this patient, is shown on the right. And so in these images, you get the fan-shaped image with the ultrasound probe in the center. And we're able to really clearly see a number of features. So we're able to clearly see the patient's uterus and the cervix. As well, we're able to visualize the tandem of the applicator within the uterus. And so we were able to quite clearly see those anatomical features that were relevant to us. And so here in a second view of the same patient, we're also able to see the ovoids as well as the source channel, which is where the radiation source passes through from our applicator. Again, we can see the uterus and cervix, the tandem as we pan through the image, and the ovoid and ovoid source channel on the other side. And so we're able to, on first glance, really identify the key features of our applicator. As well, we were able to see a number of anatomical markers, which would be important if we do want to plan. So again, we can see our uterus in this reconstructive view with the tandem passing through the center of the uterus. And in this reconstructed view, we can also see where those ovoids fall as we pass through, and you might see some bright spots in the center, which are those source channels within the ovoids. And so we found that this was a really promising first image in order to investigate this solution further in the future. And so we've had really good success at translating this system. And so most of this work has been done at the London Regional Cancer Program, but we are building additional systems for both the University of Calgary and the BC Cancer Program in Kelowna. Additionally, we've been successful looking at some commercial translations. So we've been meeting and talking with both Varian and Civco about producing the stabilizing system and implementing this system in order to try and make it more standard and more available. So overall, based on the work that we have done so far, we do believe that 3D ultrasound may provide both an accessible and a versatile approach to accurately visualize both our needles and our organs at risk intraoperatively during high-dose rate interstitial brachytherapy procedures, with automatic needle segmentation having the potential to improve the clinical utility of the system, and with some potential moving forward to be able to look at intracavitary applicators. So in the future, as I mentioned, we're going to look at implementing video needle segmentation for live real-time monitoring of those needle positions. We're going to look at the impact of errors that we see on the actual dosimetry and see if there's potential for planning on ultrasound images. And also look at perhaps doing an MRI to 3D ultrasound registration in order to bring more information about the tumor itself into that intraoperative environment. And with that, I'd like to thank everyone who's been involved in this project. In particular, I'd like to thank the staff at the Cancer Center for all of their help and support, and acknowledge our sources of funding.